Hello everyone. In today's video, we're going to talk about the landscape of health communication. What this means is we're digging into the complex system that is modern healthcare, particularly in our country. We'll talk about a couple of other examples, but we are trying to make a difference here at home. So let's see what we can get into. Hopefully, by talking about these topics, even if you don't get a complete grasp of the situation, you'll get a much clearer understanding as to how complex the system is and maybe some areas in which we could apply a little bit of change. Maybe not radical change as we remember from before, because the complex systems resist radical change, but small incremental changes can lead to big results, particularly when it comes to health outcomes. So let's see what we're dealing with. Let's start by addressing some current issues in healthcare. We have talked a little bit about some of the barriers to getting good healthcare, but this issue goes deeper than individual factors, right? We have um, probably a fair amount of agreement that the system isn't working as well as we would like it to in the United States. We seem to spend 8 times the worldwide average on healthcare per capita, and still rank really, really low in terms of our health quality outcomes. Now, there could be a lot of different reasons for that, but it's not a great relationship. We spend a lot of money. As of 2022, apparently in 2020 it increased to $12,530 per person. That's kind of a lot. That's more than other countries. For comparison, Japan is something like 4,000, I believe. And they have much better health outcomes and life expectancy. Cultural differences, there's diet differences, there's a lot of different things, but suffice to say, the healthcare system is not really working as efficiently as we would like. So we want to try and figure out ways to improve this. It's worth our consideration, especially for those of you who are going out into the world and going to be healthcare professionals or make a difference. We want to try and understand some of the causes and issues and complexities of the system so that we can try and improve it. Now, part of the reason we rank so low in terms of the actual healthcare is not necessarily because of the quality of healthcare. It has to do more with people not getting healthcare that they need. So we have pretty good standard of care in general. We've got good technology, we've got good treatments, we've got good options, but not everyone's getting the healthcare they need. Many people receive little or no care. Why is that? Well, that's a hard question for us to answer. Um, Money's probably a big one, right, in terms of people being deterred from getting access, but we'll talk about some of these factors. One thing that I would like us to talk about is the role of equity, because when we hear that people are not getting the care that they need, we ask ourselves, well, who are these people? Who are these groups of people? Is this associated with specific demographics or other social determinants of health, as the epidemiologists like to say? Um, well, to understand that a little bit better, we need to think about equity and what it means to get the care that you need. Now, we'll do that in just a moment. We want to also recognize, again, sticking with this idea of we recognize that the system's not working the way we'd like, but we can't seem to agree on how to change it. Well, hopefully by digging into some of these issues, we can do that. It might be best to try and start by agreeing on values and goals. What do we want to accomplish with our healthcare? Is it to increase an overall standard of life, of living? Is it to increase our life expectancy? Is it to get everyone equal care? Is it to get everyone the unique care that they need? But trying to figure out what we're trying to accomplish is going to be pretty useful for us. This is a good strategy in general. Know what you're trying to accomplish, and then you'll be closer to getting there. So we're going to start by examining the current landscape of healthcare and trying to figure out what the challenges are, right? And see if we can depoliticize this as best as we can. By that, I mean, try to keep your assumptions about these things off to the side for now as we learn about the issues, and then we can maybe approach better solutions. Neither political party has a particularly good grasp on this either, so you're about to know more than they do. So let's go back to this idea of health equity for a second, because if we want to talk about the goals and outcomes and what we're trying to accomplish, we need to understand what it means to be equitable in healthcare, because this is a big buzzword we hear a lot, right? We hear this in the out in the culture, we hear it in the conversations, we hear it in the political conversations, and we want to try and wrangle what that means. Um, what does it mean, and does that match up with our actual goals of what we're trying to accomplish in healthcare? Here's an example of a definition of health equity. This is coming from a different textbook. It's still a health communication textbook. I couldn't really find a satisfactory explanation as to what health equity is in our current textbook. Maybe they just don't want to wade into it. But it's important. So here's a definition coming from Schiavo, and it says that health equity means providing every person with the same opportunity to stay healthy or to effectively cope with disease and crisis, regardless of race, gender, age, economic conditions, social status, environment, or other socially determined factors. There's that fancy word of socially determined factors. I love a definition that includes other buzzwords in it. But socially determined factors, that could be many different things. But I think it's more important to recognize that when we're talking about health equity, we're usually associating health disparities, and they're correlated, not necessarily causative, that's a separate animal that we have to deal with, but these, when we see health disparities that are correlated with demographic differences in particular, and the thing about demographics is they're not a perfect predictor or indicator of things like health, but it does correlate very strongly. And so we often use demographic categories to help us determine things like what kind of care do you need, which is contingent on what sort of risks are you exposed to and predisposed to, and things like that. So here's kind of a working definition we can start working with. And it's interesting here that what they're trying to accomplish with this kind of definition is recognizing that we want to get everyone the same opportunity to stay healthy. Same opportunity to stay healthy. Note that that is separate from different outcomes. You can't guarantee equal outcomes. Well, you can't guarantee equal outcomes in anything, particularly with health. It's just the nature of health. We all have different health. We all have different injuries. We all have different diseases. We all have different risks. We all have different conditions. And we all have different health outcomes. But the goal is to make sure that people can get the care that they need. So here's something that you can work with that it should be easy to remember. The goal, I think, for our purposes, should be to aim for an equality of access to care. Right? We want to make sure that everyone has the opportunity to access healthcare, to access the care that they need. And then we would like equity in care. Equity meaning we want people to get the care that is appropriate to their unique needs. If you need a way of thinking about this, well, here's a different metaphor. You're trying to learn some information the old-fashioned way, and you got to get into the library. Well, we would like everyone who wants to learn that information to be able to get into the library. That would mean getting them a library card, right? Then, once they're in there, then they can get the different kinds of information they need, answer their questions, whatever it is. But getting access into the system is the first step. And so when we're talking about equality, equality of access is about the best that we can do. Equity, however, means that we're trying to get people what they need. So if you have a brain tumor, you probably need brain surgery. If you don't have a brain tumor, you don't need brain surgery. It's pretty straightforward, but it's important for us to remember that health is an innately distributive exercise. Healthcare is it's discriminatory in the sense that not everyone needs the same care. And so the goal is to make sure that everyone can get the care that they need, which will be unique. And in order to do that, we want to make sure that everyone has a quality of access to that care. Part of this might be ethics. Part of this is just being part of a society, because when you have unhealthy people in your society, we all end up paying for it somehow, one way or another, whatever it may be. So let's continue from there. We want to try to get an equality of access to care and equity in care in terms of getting people the care that they need. That care may be related to demographic differences, but we deal with everything on a case-by-case basis. The goal is to try and create a situation in which everyone can get the care that they need. Now, another important aspect of this, and this is probably getting deeper into the philosophical or ethical musings on this, but it might be worth asking if there is a trade-off between helping individuals. So the equity of care, right? Treating people as people and dealing with each individual individually, versus helping groups, which might be the goal of equality of access, right? So when we think about this being politicized, when we're talking about equality, we're trying to get different demographic groups the care that they need, and so we're trying to alleviate health disparities in that way, right? So maybe we need to try and get a specific minority group more access to a specific service, something like that. There might be a little bit of a trade-off in this, because the more you focus on demographics, demographic groups, there might be more deterrence from focusing on people as individuals. Not all the time, and this might be more of a question than a fact, but I'd like you to think about this. There might be a balance to be struck here in terms of, or maybe rather than the seesaw image I've created here on the PowerPoint, it might be more appropriate to think of this as like a magic eye. You guys remember magic eyes? You look at a weird, like almost random pattern and you unfocus your eyes just enough that you can see the hidden image in there. Well, maybe that's what we're talking about. We have to be focused, but not focused so focused that we can't see the big picture, right? So there's probably a little bit of a balance here. We can't do all of our policies in terms of fixated on equality, other than trying to get equality of access so that everyone can get things. So anyway, that might be worth considering. And there's also this additional consideration of who's responsible for this. And that's a question that people have a really hard time answering. But if we're looking on my diagram here, the fulcrum of this seesaw is the healthcare system and perhaps the government. Is that who we're dealing with? In most cases, probably yes. When we get into the universal systems and things, we're usually talking about governments intervening on behalf of their own citizens to make sure that they can stay healthy. Yeah, I think most people could probably agree that there is a role for the government to play in making sure that their citizens are healthy. What that looks like, well, that can get a little more complicated. Now we can spend a bit more time brainstorming some of the actual barriers in healthcare and being a little bit more specific as to what the challenges are. That can help us start figuring out what to do about some of these things. So what kind of challenges are we currently facing? I want you to ask yourself that question and see what you can come up with, anything else that doesn't appear on this list. What kind of challenges are we facing in terms of our healthcare system? As a country, as individuals, what kind of barriers do you face in terms of getting the care you need? Well, early and preventive care is probably cheaper than acute care. That seems to be pretty consistent in terms of what you see in the research. But getting people to pursue preventive care is a little bit harder than getting people to pursue care when they're injured, for instance, right? People are somehow more resistant to regular exercise and a healthy diet instead of just going to the doctor if they sprain an ankle or whatever it may be. But in the long run, if you can increase the emphasis on wellness and preventive care, outcomes are going to be better in the long run. There's going to be fewer catastrophic outcomes, and those are much more expensive as well. Healthcare access, well, that's a big one. We could talk about this in a couple of different ways in terms of whether or not you can take the bus to the doctor, or you can't, or you don't have a doctor in your town, or you don't have the money to access a doctor. Well, these are all pretty important things too. Money is a big one. It's strongly predictive of life expectancy, right? In terms of poverty being a pretty serious killer. Now, is this, again, we could always ask ourselves the correlation versus causation. Is it the poverty that causes early death, or is that associated with different countries, right? Is that your country is developing, which means it doesn't have as much money and therefore it also doesn't have as much health care, or does it mean that poor people can't afford to go to the doctor, right? Those are different issues too, but it's safe to say that money is a pretty strong correlate in terms of predicting life expectancy. Now, we also have the complexity of the system in terms of just, well, we're talking about a lot of stuff today, and it's confusing stuff, and you're probably not going to get it right out of the gate. You're probably not going to have a really good grasp on these things. It's a complex system, and that makes it harder for you to get the care that you need because you may not know what that care is, and there may not be a clear answer to help you find out what you need. So how does healthcare work as a process? And you can reflect on that as well. When's the last time you had to go to the doctor, and how did that work? It might be pretty simple here on campus. You can just go to the student health center. Or if you grew up around here and you have your family doctor nearby, and maybe it's not that big a deal for you. Many of you are probably under the age of 26 and probably on your parents' insurance, and you probably don't have to worry about this as much. But these are real questions in terms of even if you don't have to make those decisions for yourself all the time at this stage of your life, think about how opaque that system is to you. Do you understand how that works? Do you understand how much that you would have to pay when you go to the doctor versus a specialist versus something else? Well, it's a complex system. And we have a need for structure, and it's hard to say how much structure that would be. So the more complex a system gets, the greater the need for understanding how that system works. And so the government is usually put in a position to try and manage this in some way. And so then the question becomes, how much structure should the government impose on the healthcare system? Maybe we have enough information to start answering those questions. Maybe not, because there's a lot of other considerations we can address, such as diversity and culture. Right? There are cultural differences across countries, across rural and urban divides, across regions, across states, across county lines, whatever it may be. And so how much structure should we impose on the system, and who should make those decisions? That's a hard question to answer too. You'll see those kinds of discussions of, well, I don't want people in California making decisions for people here in Walworth County, or maybe people in Alabama shouldn't be making decisions based on healthcare or about healthcare for people on the West Coast. You can take that any way you want. It's the consequence of having such a diverse culture. Because when we start looking at something like healthcare reform, it's tempting, excuse me, it's tempting to say, well, we should just do what they do in Japan. It may not work here because Japan is a homogenous culture. They're all Japanese. They share a lot more concrete values. People in California and Alabama, good luck getting them to agree on anything, right? So diversity matters in a lot of different ways in terms of cultural differences and what we expect, what we want from our healthcare. Now, as the system gets more complex, that adds a necessity for people to help you navigate that. And the book has an interesting discussion about healthcare navigators in the Australian system that help pair people with providers and answer basic questions and things like that. Well, the more complex your system gets, the more useful people like that become. And so you can see that as a good or a bad thing, right? Maybe that's job opportunities right there. But then you still have to create those jobs. You still have to employ those people, and they are going to be necessary. So if you don't have those navigators in the system, people are going to be lost. Now, additionally, in this complex system, um, if you don't have a navigator and you're confused about it, there's some useful tips the textbook gives us in terms of how to navigate this system. And I think these are worth reviewing just because they might make your life a little bit easier if you follow some of these tips. So, first of all, it's good to try and develop a relationship with your primary care physician, your care provider. If you have some say in this, right? If you don't have a very good relationship with your care provider, you're going to encounter more obstacles to good communication and getting the outcomes that you want. So trying to have a relationship with your care provider, develop a rapport, talk to them, interact with them like a human being. I always try to make any nurse or doctor I see, I always try to make them laugh at least once in the interaction so that they remember that I'm a human. But I rely on my humor a lot. At least I think I do. I think I'm funny. I make myself laugh sometimes. So I try to do that, or at least show them the goodwill that I'm trying to interact with them like a human being, even if they don't think my jokes are funny. You can also recruit a personal health care quarterback, as the textbook calls it. This is referring specific research that found that people had more success when they had some kind of partner in their healthcare. This could be a spouse or a significant other, your parent, um, or someone else, a friend, your best friend, who knows, right? But people do better when they have support networks, when they have people backing them up, right? Couples experience greater gains and better health outcomes when they go to the gym together. They stay committed to it. It's harder to do that on your own. And when you have someone to encourage you and collaborate with you, that helps. And so same with your health care. Someone to bounce ideas off of, help you remember to take your medicine, get your appointments, all that kind of stuff. It's really important to have someone in your life that can help you with that. You can maintain a roster of key players. What are the different healthcare providers that you see? Are you someone with a chronic condition and you see a lot of specialists? Well, maybe you should keep a list of those people, their contact information, and share it with them so that they know who the team is, right? Because healthcare is a team. And for people who have more chronic conditions, well, that's certainly a consideration. I myself have psoriatic arthritis, so I have to see a rheumatologist. I have to see a primary care physician. I have to bounce around these different people. I used to see a dermatologist because that's the nature of psoriasis. Now, this is a chronic condition that is mostly kept under control, but I have to visit a lot of different people. That's just the way it is. And I get confused. I've moved a lot. Sometimes I forget where I had that rheumatologist in what state. But you can see how these things get complicated really quick. You don't have to have a chronic condition like that in order to just forget to go to the dentist, right? There's a reason they send you reminders. You have a dentist, you have a physician, you have the place where you go get labs done, you have a pharmacist. Make a list of those people and their contact information so that you know that big picture. Keep and share clear records of your meds, visits, allergies, etc. If you write this down, you can make a little worksheet. You make a handout for your doctors. They'll probably thank you. It makes their job a little easier rather than having the nurse ask you the same questions every time. Give them an updated list of your meds. And network with support. So similar to recruiting a personal healthcare quarterback, this can be a nice way to help yourself out, right? You have parents, loved ones, friends, teachers, whoever may be in your life that can help support you. And that's both in social support and also in instrumental support, such as reminders of things and bouncing ideas off of. My father is a retired toxicologist. Anytime I am thinking about taking a kind of cold medicine, he's the first one I call. And I say, Dad, is this going to have some weird interaction with like Advil or something? And he's like, nope, right? But he's part of my support network. And I'm sure many of you rely on your parents in a similar way, even if they're not retired toxicologists. Dad, how do I call the insurance company? Mom, when's the last time I got vaccinated for Tdap? And all that kind of stuff. It's important to have those networks, so don't forget about that. And last here, a really good tip is to listen to your body. Right? The book mentions if something feels weird, yeah, it might be weird, right? You know your body better than anyone else. And so if you are worried about something, go see a doctor. That's a great practice. So these tips can help you in any healthcare system, but particularly one that is, as the book says, fragmented, right? It's a complex system, a lot of moving parts and a lot of players. And so some of these tips can really help you navigate that kind of system. So thinking about health communication in this context, and the context being the changing world, the modern world, it's probably worth it as we're exploring the complexity of these systems to recognize the complexity of communication and some of the factors that contribute to that complexity. In particular, the textbook covers a few of them. One of them here is global health risks. Well, we probably don't have to dig too far into this to recognize how the nature of health has changed a bit in the past, I don't know, century. Things move a bit faster now than they did 100 years ago. Globalization is a huge factor, and as the coronavirus pandemic has illustrated for us, things can happen pretty quick. It only took a couple weeks for that to be all over the world, depending on when you think the start date was, right? And the nature of the coronavirus, of all coronaviruses, is such that it's very difficult to contain. Perhaps the 2 weeks to slow the spread kind of attitude was unrealistic. A lot of epidemiologists thought so at the time and continue to think so, that those kinds of lockdowns and those drastic measures, well, it's just not going to work with a virus like that, which is going to be spread through aerosolized particles and contact, close contact, prolonged contact, isolated space, and other aspects of the virus itself make it easy for it to spread. This is kind of an aside, but we could compare it to something far worse, such as the Ebola virus, which I won't discuss you with the symptoms of that other than it's lethal and it kills you usually in like 2 to 3 days. So what's interesting about that is that Ebola outbreaks are kind of self-limiting. Why? Because they kill people very quickly. Something like the coronavirus is a little bit more benign, right? A lot of people died, certainly, but it's not quite the death sentence that the Ebola virus is, which has like a 60% mortality rate, as I recall. It might be lower than that. It might be even like 30. I should look that up. I'm going to look that up. Hold on. Yeah, it seems to be 50%. And it's anywhere between 25 and 90%, according to Wikipedia. So that was a quick search. But yeah, my memory serves me correctly. It's about a 50% mortality rate, which is still lower than a lot of people assume it is. But it kills people so quick that it doesn't spread very quickly. Whereas a coronavirus does spread very quickly because you feel bad for a while, and even if it eventually kills vulnerable people, it's not going to do it right away, right? So it spreads much easier. These are some basics of epidemiology that you're not epidemiologists, and I don't expect you to be epidemiologists, but we can at the very least recognize the complexity of a globalized community. So moving on to another factor here that is part of this changing context of health communication, healthcare in the world, is the fact that we have an aging population. So we have an aging population in the United States, and most developed countries in the world have an aging population as well. Well, why would that matter? You can probably use your imagination. As we get older, we have greater needs for healthcare and interventions. And that's just part of it. Most developed nations have an aging population for several different reasons. We don't need to dig too far into that other than to recognize that first world nations tend to have a slowing birth rate, a rate between 1 and 2 kids per couple, or per woman specifically. Whereas what we commonly consider to be third world countries or developing countries tend to have higher birth rates. So they have a growing population. Developed countries have, like our own, have a shrinking population and an aging population, and that has some serious implications for healthcare. Japan's a great example of this. So for the first time, people over the age of 75 make up over 15% of the population in Japan. That's kind of a lot, right? 38% of Japan's population is over the age of 60. The US, by comparison, has about 22% of their population. This is a big deal for Japan, right? They have a low birth rate and an aging population and a nationalized healthcare system. So that means the government's picking up the bill. Now they're still spending about like 40% what we do per capita on each individual's healthcare in Japan. So that seems to be working pretty well for them. But it is going to be an increasing issue and cost for them in the future. Related to these topics is diversity. So that could be in terms of the cultural context I described earlier. It could also be tied to migratory trends of humanity, right? We have people moving. So I mentioned previously here that Developing nations tend to have a higher birth rate, a younger population. That means a lot of the laborers are going to be migrating around the world. And you see this in whether it's in political arguments about what we should do with migrants, legal and illegal, what we should do with refugees, all that kind of stuff. Well, those conversations are only going to become more common as we go forward because you will see migration of people from developing countries to developed countries. You see this in Japan. There's an influx of foreigners, and they make it very difficult in Japan for foreigners to feel at home in Japan or to even get there and stay there and work there. And so immigration is going to be an issue for them going forward, just as their population continues to age. To maintain their population, they're going to need more immigrants. They're going to need more babies, and I don't know, maybe more robots is what they've been working on. But you see this in all first world so to speak, countries where you have a migration of labor, and that changes the nature of healthcare. What does that do to the culture? And what does that do for the fact that outcomes are better when your doctor looks and talks and thinks like you, right? So those cultural boundaries are obstacles to healthcare as well. It also introduces those intergroup tensions. So as we start, this is probably what you're most familiar with from watching TV and the news, right? Is when you have any migratory populations, migrant labor, whatever they may be, immigrants coming into a country, well, it creates tensions with the groups that live there already, and that can be problematic too. It can become violent. It can become just conflicted in general, but that's a big conversation that we can have later on as we dig into diversity in Chapter 6. Technology. This is a huge game changer. How many telehealth appointments have you had in the past 3 years, right? There's good, there's bad, and there's ugly with this. Technology is increasing our access to information. It can allow us to look things up instantly, but it can also allow us to be exposed to information that is less reliable than other information. And unfortunately, the line between the two is getting blurred, particularly when we consider that in the context of the previous lecture and the noble lies of the government pertaining to COVID. The fact that there's so much information available, good and bad, makes it all the more important for us to care about conveying information as honestly and accurately as we possibly can. Well, you get the idea. But all of these things are changing the way we do healthcare and the way health communication manifests and functions in our society. And we should be asking ourselves the questions of what is that going to do and how can we make that work better? Now we get into the really exciting part of the chapter, which is the different kinds of managed care organizations. I'm not going to go through all of this per se, but this will be available for your reference. I've also put the slides for this lecture up on the Canvas page, so you can look at this at your leisure. And while that may not seem like a ton of fun to you, these are important things to know the differences of. Even I made this table as much for myself as for you because I find these things confusing as well. And anytime I get a new job, I elect into benefits, health insurance and whatnot. And I'm not totally sure I know the differences of these different things. And that's important because I've got kids and family to look out for, and I have to make these important decisions. And you probably will someday too. Again, recognizing that many of you are under the age of 26 and don't have to worry about this stuff right now, well, that's all the more reason to be concerned about our literacy with these ideas. So what we're looking at here are managed care organizations. Managed care organizations have kind of replaced conventional third-party insurance as of like the 80s. And we kind of use the terms interchangeably. Like these are pretty much your standard insurance companies here. Now, the main thing that you should take away from this is that there are major differences between these kinds of groups. All right, you have your HMOs, which are health maintenance organizations. You have your PPOs, which are preferred provider organizations, and you have high deductible health plans, which are just kind of these bare bones insurance situations. Now, what the advantages and disadvantages of each of these are, well, they're kind of tricky to lock down because there's a lot of overlap and some things are both advantages and disadvantages. But I think what's most important for you to recognize here is that depending on these different organizations, you're going to get different costs and different benefits. Now, a health maintenance organization, you might think of this as kind of a health co-op. This is designed to limit the costs to pretty much everyone and increase the efficiency of the system. But the textbook raises this concern of a conflict of interest here, because what we're talking about with a HMO is that the doctors and the insurance company are kind of the same entities, right? They're the same organization. You are, with an HMO, limited to picking doctors who are part of that organization, and they set those things. They set those copays, they set those premiums, and usually the prices of care. So there's a little concern about the conflict of interest there, but HMOs are designed to reduce the costs substantially, and so it's a bit more affordable as long as but you're limited in your options, right? You're with those limited prices, copays, meaning that how much you pay per visit, and premiums, meaning how much you're paying just to have the insurance, right? And you're also limited with who is part of that organization. You have to see those people. The preferred provider organization, a PPO, is a little bit different in terms of these are kind of doctors and offices that are independent contractors, right? They are applying and contracted through the PPO to give special prices, discounted rates, limited premiums, more choices, all that to people in that organization. So you have a list of doctors with this one, right? You can go see people in network, right? And if you go out of network, you're going to pay more to see those people. And so you still have this kind of limited list of doctors that you can go see, but it's also more affordable. Now, the high deductible health plan, what that means is, say you're 20 something, as most of you are, and you don't have any health problems. And so you think to yourself, well, why would I bother paying a bunch for health insurance when I don't need it, right? Well, so the high deductible health plan is kind of the answer to that. The monthly premiums, meaning like your membership fee, right, is much, much lower. And you are also eligible to make what's called a health savings account. That's untaxed money that you can put in a specific account to spend on your health care when you do need to spend money on health care. Now, the downside of this is that the deductibles, meaning the amount of money you have to pay before insurance kicks in, is much higher. And there's a much higher catastrophic cap, right? So for these other organizations, deductibles are lower, as in like, you pay $1,000 that year on healthcare and the insurance covers the rest. But with a high deductible plan, the deductible might be more like $4,000, right? And you're going to be paying that straight out of pocket before the insurance kicks in at all. There's also higher catastrophic caps. Catastrophic caps being like, that's the maximum amount the insurance company will ever make you pay. And so that's going to be higher with a high deductible plan too. So there's a trade-off on all these. And so while you don't need to memorize all this right now, I think it is useful for you to have this overview, and you can reference back to it as you see fit. It's all very interesting in how it works. These are different options, and there are concerns with all of them, right? So for instance, this idea of what does it mean to have your healthcare be contingent on a fee for service kind of model? What does that do for the incentives? Does that incentivize insurance companies to be more difficult in terms of whether or not they approve a certain course or treatment? Or does that incentivize hospitals and doctors to be like, all right, you need an MRI, even when you don't, because it's so expensive and they want to make the money, right? So part of the issue of insurance in general is this tension between doctors and insurers, right, who are all trying to make money, and which they have a right to do. They should. We're all trying to make money, right? But we need to ask ourselves as we think about what's best for us and what's good for the system and how we can reform things even. Where are the incentives? Always ask yourself that question. And sadly, we have to ask that question in healthcare as well. But you could think about which one of these plans makes the most sense for you, given your constraints. And hopefully, this overview helps you start to understand what that's going to look like. So what you're looking at now on this screen is an example of I think a PPO. You see, even I'm not totally sure all the time, but this has all the telltale signs of a PPO. This is the kind of the standard insurance package that is offered through the UW system to all employees. So this is, this is what the university and others do. Now you can see some of the telltale signs of a PPO here, right? These differential co-pays for different kinds of visits over here. You can see out-of-pocket limits, right? The catastrophic cap for the year, right? For an individual and family. You can see deductibles, right? So I believe this says somewhere along the lines that each individual, right? So with a family plan, each individual has a $250 deductible. So everyone in the family, once they reach that cap, then they don't pay anymore, right? And so then you also have these other different co-pays, right? Depending on the type of care. So this is all indicative of an insurance, like a PPO, right? Preferred provider organization. So that's what we're dealing with here. So this is very much in the real world. But if this is boring to you, I'm not surprised. It's boring to me too. And I have a hard time wanting to, to figure all that out when I accept a new position. But that's part of it, right? So most of you probably don't have to deal with this stuff, but you will eventually. Now, just overall, managed care organizations, just as kind of a summary here. There are pros and cons, and the textbook does a pretty good job of laying these out. And these pros and cons really, I mean, this alone gives you probably a pretty clear picture as to how confusing and complex and a mixed bag our current healthcare insurance climate is, right? You can see that the benefits of this are that you have predictive budgeting. You can budget when you have insurance because you've got your set premiums, your expected copays, and theoretically limits to how much you're going to get stuck paying, as opposed to someone who's uninsured. They get in a car accident, there goes your finances, right? There's also theoretically the incentive to reduce costs with this because you have the market pressure of insurers arguing with hospitals to kind of stabilize those costs. Is this as efficient as, say, the Japanese system where you have the government and the government Ministry of Health officials negotiating with physicians who are in charge of hospitals directly? Every year they negotiate prices and they keep them low that way. Is it as efficient as that? Probably not, but theoretically, having insurance companies in general should be an incentive to reduce costs. And that should lead to more affordable care. It should lead to more expected wellness, particularly when we think about this key term of capitation, where we're paying a little bit every month instead of, again, a ton of money if you get in a car accident or something. That should promote wellness and limit costs. Now, you also have the benefit of administrative assistance and teamwork. So if you're a provider, that's useful to you, that you have these systems that can support you and help you work with the paperwork. And then it also provides jobs and security for those kinds of people who are working those jobs. Now, the other side of this stuff, of course, is that, well, that's a lot of bureaucracy, right? And that creates a lot of red tape, miles and miles of red tape. And this other table here, you can see a lot of physicians think that this unnecessarily complicates the system. They're not satisfied with this, and they think that the insurance companies kind of try to hold out and send things back and forth, and that limits both products and productivity and health outcomes. Now, we also have this problem of limited choices because the managed care organizations are dictating what kind of procedures patients can afford getting and what kind of doctors they can see. And there's also this incentive to limit care, right? So while it's theoretically incentivizing insurance companies to try and make things cheaper, it's also incentivizing them to not recommend people to get treatments that they might actually need, or to make it difficult for them to get more expensive treatments and things like that. Now, ultimately, we also have this other problem of prevention is still not the emphasis in this system. And as I've said before, this could be a cultural thing. In our culture, we don't really emphasize prevention as much as acute care. We don't emphasize wellness, and that's probably, if I could snap my fingers and change one thing about our culture, our healthcare culture, that might be it, that we emphasize a little bit more holistic prevention, wellness, that kind of stuff. Man, I mean, that's an oversimplification. There are a lot of other big problems too, but I think that that's an important one. And there's a lot of other important stuff that I probably would, if I was pressed, prioritize. I'm kind of hedging my bets now, but you see what I mean. I think that prevention and changing our cultural attitudes about health in general would lead to a lot better health down the line, rather than focusing on this kind of what shot's going to fix what thing. That's not a sustainable model, right? You need to have people prioritizing their own health in order to have good health outcomes. So, and then despite all of this, you still have rising costs. Is this because of the guaranteed business of having insurance companies and the Affordable Care Act? It's hard to say. This is complex stuff. But hopefully this kind of table helps you see that this isn't as clear cut as saying, all right, insurance companies are evil and doctors are greedy or something like that. It's not that simple. And we're going to get into that in the next class's lecture as we talk about patient and provider dynamics, and we're going to start becoming more empathetic to providers' perspectives, I believe. So healthcare reform, how can we fix it? Can we fix it? Well, there's a couple different options that a lot of people talk about, and we should engage with these quickly as well, even though this video is getting a little long. But one is universal coverage. You've probably heard this term before. It's tossed around a lot as a solution to kind of the insurance issue. So with all the insurance, different organizations, different insurance companies, different incentives, and the complexity of the system, well, things get a little out of hand, and it's kind of hard to keep a tab on things. Universal coverage means that you're guaranteeing health care to all citizens and beyond sometimes, depending on the country or the culture. So that could look like the Japanese system, where they have a national health insurance provided by the government, and then there's also a supplemental insurance. That would be a multi-payer system, which we'll get to in just a moment. Now, questions regarding universal coverage, or when people are starting to debate whether or not this is the right way to go, often what we're talking about is, well, what is the role of personal responsibility in your own health, right? People really don't like the idea of paying for other people's health care. Now, but to some extent, that's unavoidable in this system, right? It may feel unfair to have to pay someone else's way, as it were, but healthcare is one of those things that even if you're not doing it officially, you still have to foot the bill in some way, because we're all part of society. We all have to deal with the consequences of a healthier and healthy society. So, we have to decide maybe where to draw that line. Well, like, what's paying enough? Or like, should we pay a percentage of our means? Should we pay as much as we can afford? Should this be entirely charity-based? Should this be entirely tax-based? Whatever it may be. But you also have other concerns here, right? You have concerns with like wait times, for instance. You see that as a criticism against universal systems. In Canada, you hear a lot of stories, a lot of horror stories of people who are stuck on waiting lists for months, years, not getting the care that they need. And those people then complain that, like, well, I would rather just pay more out of pocket if it means that I can get the care that I need. So again, go back to that diagram that I drew of, are we talking about equity of care, right, in terms of people getting the care that they need, or equality of access? And if we prioritize this one too much, well, then people may not be getting the care that they need to ensure that everyone gets a chance to see a doctor, but they may not be able to see the doctor in time, right? So it seesaws back and forth. That was what I was trying to capture with that diagram. Now, a single payer system, this is this could be a form of universal coverage. If it were just the government sponsoring it, that's a single payer system, right? So that would be a government or national healthcare system. We would compare that to a multi-payer system. I don't know how many true single payer systems there are. Most of the examples I can think of are truly multi-payer systems, such as the Japanese example. So we're talking about a mix of insurance. So you have the national health insurance program, but then you can also buy supplemental health insurance. So for instance, the Japanese health insurance, when I was living there, did not provide for dental care. You had to pay for that. Now, the costs were still pretty low, though, so paying out of pocket was pretty cheap. And that's kind of the benefit of that. Well, in that case, the multi-payer system still keeps the prices low, but you can still get insurance on top of that. So what that looks like, a brief anecdote from my time living in Japan. I had a number of healthcare things done there because I was there for about 3 years. Um, and I've had healthcare done in Japan since I have stopped being employed there. So we can compare that too. I had my tonsils out in Japan, and they're very big on having people in the hospital. So I was in and out of the hospital for like a month, all said and done, with like, oh, I had tonsillitis, we should get the tonsils out, whatever. And I remember the doctor asking me, well, don't you want to wait until you go back to America? I was like, nope, nope, take them now. But anyway, all said and done, I think with the national health insurance, that costs something like $2,000 for about a month in and out of the hospital, having a surgery done, anesthesia, all of that. With my educator's supplemental insurance, I paid a grand total of $50 when all was said and done. That's a little different. That's about as much as I pay for a specialist visit for just copay here in the States. Another example is when I have since visited Japan and was not insured at all in that country, and I had a sinus infection. I just had to do something. Went to the doctor, saw the doctor, got a prescription for antibiotics, and that also only cost me about $50 or $60. They're like, "Are you sure you're gonna have to pay? You don't have insurance." And I was like, "Well, it is what it is," and it was still cheaper than it is in the States, right? So there seems to be some benefits to having some form of government intervention, or at least some consistent external pressure on price setting. But you also have to keep pressure. It can't be a totally for-profit enterprise, because then you have those kind of escalating costs. So maybe I'm making an argument for the government stepping in. As I said before, I think the government has some role in this, and it's up to us, it's up to the individual culture and the citizens to decide how big a role we want them to play. Health might be one of those things that would be best if you have one authority in charge of that, rather than have everything subject to the complexities and inefficiencies of the system and escalating costs. Now, another problem that you might see in multi-payer systems is what's called a coverage gap, right? So that would be, for example, you're not poor enough to be on Medicare, for instance, in the United States, but you also don't have enough money to afford really expensive insurance. That creates a coverage gap, right? Which is one of the reasons why our system is kind of inefficient. So we do have a multi-payer system, and you could see, depending on the definition, you could probably throw the United States system and the Japanese system are both kind of multi-payer systems, but done a little bit differently with different priorities. You also have another fun word here is the individual mandate. You might have heard that before. And what all that means is that everyone has to have insurance. Right? That's a legal requirement of our current system as of the Affordable Care Act in 2010. The Trump administration reduced the penalty for not having insurance to 0, however. So is that temporary? Is that forever? We don't really know. But what that means is that, like, well, yeah, you're legally required to have insurance, but there's 0 penalty for not. So that kind of allows people to not have insurance, which is, again, do we care about that? Well, even if they don't have insurance, well, here's the catastrophic example. You do get hit by a car. You don't have insurance. You're in the hospital. You don't have a choice. Someone took you to the ER. Ambulance ride costs $10,000 out of pocket if you don't have insurance. ER visit, thousands of dollars, right? You don't have that money. So the hospital system is then footing the bill, which means the government's going to have to reimburse it and all that. And so that's kind of one of those examples of how, even if we're talking about personal responsibility and like it's my problem if I get hit by a car and I don't have insurance. Well, yeah, kind of, but it also is the system's problem, and that system feeds into itself, and it creates all these other weird incentives and secondary markets and all that. So again, the complexity of the system means we're kind of all in it together, whether we like it or not. What's the best solution? That question remains. So now I've given you kind of an overview of some of the factors involved here and some of the options. And hopefully you've been thinking as we go along here about, well, maybe that would work, or maybe that wouldn't work. I would like you to think about this. And obviously these are kind of rhetorical questions at this point because we're not face to face and having a discussion about this, but I want you to be able to think this through. And it might be useful to you on the discussion boards to investigate these kinds of questions. consider that as that comes up in the discussion this week, because I imagine it will. People will be like, I think we should do this system. What are your thoughts on it? So this could be a warm up for that. But how would you go about fixing this system? Do you like the idea of kind of that Japanese system where the government has enough of a role that they can keep prices down and that negotiation? So you've got the physicians or the counterbalance to that. What's going to work here? But maybe it would be helpful for you to think about this in terms of what is the most pressing issue in healthcare? Do you think it's access to the resources? Do you think it's equity? Do you think it's health literacy? Do you think it's truly the complexity of the system, right? What is the most pressing issue in this? And then the next step would be, well, what would you do about it? If it is the complexity of the system, do you think we should have kind of a navigator program of some kind? Should that be sponsored by the government? Next, I want you to think about what would be the criticisms that someone would levy against that position. And can you think of reasons why those criticisms should not really derail your plan, as it were? Take a little bit of time to think about that after you finish this lecture and you ruminate on these ideas. Maybe bring it into the discussion boards. I want to see what you come up with, because there aren't any easy answers, but that doesn't mean there aren't some solutions and things that can be made better. I know this video is getting a little long, so we'll try and do this as quickly as we can. We're almost done, I promise. But I do want to take a moment to think about the provisions of the Affordable Care Act, since the textbook goes ahead and mentions that, and we've been talking about it. It would probably help bolster your arguments to know what we're dealing with now. So in 2010, this did in fact pass, and this is kind of the system that we've been dealing with ever since. Some of the things that they made sure got into this, which ultimately had to be a bipartisan agreement. They had to get this through Congress. They had to trim a lot of things. They had to adjust a lot of things. But here's what we got. We have guaranteed coverage of the essential 10, as they say. That would be ER services, outpatient care, hospitalization, maternity services. Having babies is super expensive. I can tell you from personal experience, at least in this country, it's very, very expensive. You're talking like $4,000 to $7,000 for having a kid after insurance, right? Don't even get me started on childcare. That's really expensive too, to the tune of like $14,000 a year. Mental health services, that's another one that should be covered by insurance according to the ACA. Prescription drugs, rehabilitation, lab work, pediatric care, taking care of our kids, that's important too, and preventive care. Preventive services should be covered. Now, another thing that got added, and this is probably most relevant to you guys if you are under the age of 26, odds are you're probably still on your parents' insurance, because the ACA dictated that coverage be extended up to 26 years of age, probably because of the trends of more and more people living with their parents, more people going to college, getting education, and delaying their entry into the workforce. But I imagine many of you are benefiting from that provision now as well. Now, we also have guaranteed or demanded, mandated free prevention and wellness exams. So that's nice, right? We're emphasizing more prevention. How effective are those programs? Well, that's a separate matter. You could always do some research on that if you feel like investigating. There's probably a dissertation in that if you want. And they also banned pre-existing condition clauses. So that means someone who like me has psoriatic arthritis could have been denied coverage if the insurance company is like, nah, you're going to be too expensive, right? That was a problem, and we did get rid of that. Now, where do we go from here? Do you think that's enough? Do you think those provisions are enough for our system? Some benefits, some criticisms are that it's the ACA also, by adding an individual mandate, for example, it's guaranteed business for the insurance companies, and well, maybe that's not exactly what you have in mind if you're trying to decrease costs, for instance, or decrease costs of insurance. Now, where do we go from here? That's a very hard question to answer, and I'll encourage you to think about it and engage it as we go through the course, and hopefully we'll equip you with more information to answer that question. It may require us to challenge our own political beliefs. Go beyond what your political party thinks. Spoiler alert, None of those people know how to solve this problem. And if there were a clear answer, we would have done it by now. It's going to take collaboration, it's going to take imagination, and it's going to take cooperation, and it's going to take us going beyond our political beliefs. What can and should we have faith in as a society in terms of developing our healthcare system? And what should our goals be? We may have to take kind of an earnest look at what we want to accomplish here. And we need to decide what to have faith in as a guiding principle. Is that the Hippocratic oath of do no harm? Is it to reduce disparities, health disparities across groups? Is it to encourage personal responsibility? Is it simply to reduce costs across the board, get our spending under control? Well, a lot of people have different priorities, but I think we can agree that some things are really, really important, and we should try and get those taken care of. I hope you found this interesting and useful. I know some of it's kind of dense and boring, but this is all very important information. And while I don't expect you to have all this retained right now, I want you to have at least this rudimentary understanding, and you can reference back to this as we go along to try and figure out how you fix things like this, because that ball is going to be in your court. You guys are going forward. I assume some of you will end up doing something related to healthcare eventually, and if not, it at least can influence the way you vote, the way you think, and the way you talk about these issues. So, good luck.